Thank you, Arup. Am I audible and are the
Yeah,
slides visible?
clear,
Okay,
clear.
right. Thank you, Arup, for including me here. And today I'm going to discuss about the early detection and management of complications. Well, I'd also like to thank Dr. Arup Bhaumik and Dr. Ayan Mohanto for lending a few very high quality award-winning teaching videos here. Well, uh, at the very outset, I'd like to say that we need to observe keenly. We need to look for, the kind of cataract. These certain signs and symptoms which would give us a hint that this case is going to be difficult, and then that alertness will help us to detect early and manage accordingly. Well, it could be a dense cataract. It could be, a wobbly lens with weak zonules, a small pupil, or a very elderly and deep-set eyes and narrow palpebral fissure. All these we know are difficult situations. And even we shouldn't miss out on small little things like proper positioning of the patient. It still remains critical when the case is really difficult. So all these we need to look into. And I approach for phaco in almost all my cases, in all my cataract surgeries, but always remain steady. We need to be steady and alert, but we should mentally be ready to switch to SICS or ECC or whatever method would be good in the management or avoiding the disaster. So we shouldn't, wait to switch. It should be a timely intervention. Let us go with this video where, as you can see, it's a dense hard cataract with the rexis done. At times we need to enlarge the rexis as has been discussed and stabilizing the view with the iris hooks. And as you can see, repeated chopping is being attempted, but yes, it really gets difficult and we need to understand this is when it's time to convert. So the lens becomes wobbly. Let us remove uh, the iris hooks and prepare for uh, SICS. So no ego should come in between. It's saving the patient's eye, giving him good vision. That is what is the sole motto. So we need to escape this disastrous situation with converting. So we put some visco and then yes, homegrown wire snare is used to chisel this dense nucleus, and it can divide these hard nuclei into smaller pieces. And once we achieve that, those small pieces are achieved, we can always just take out one by one using a forceps. So once these hard pieces, once they are out, you will realize how hard they are. And once these are all taken out, we can always go ahead, clear up the cortex and implant a lens, right? So that is how we can manage these cases without going in for our ego to complete a phaco. We can at least achieve good centration of the lens, a good stable lens inside the bag, and we can go ahead to give the patient a good vision. Now, this is another hard cataract. This is hard, but not as rock hard as the one before. So here again, we start chopping. And as you can see, this a little leathery kind of a cataract. And you can see those fibers there. And as has been discussed, it needs a multi-level chopping. But yes, when the posterior plate is not broken properly, it may just tumble. And yes, you can see that turbulence. And we need to realize there is something wrong. We shouldn't take out the phaco probe like what we have done just now. Handpiece shouldn't be removed without giving some visco inside. But this case we were lucky and nothing happened. So these pieces were taken out. There's a big PCR. We can do a little bit of anti-vitrectomy. It's preferably to be done from pars plana, but it's okay if you can manage. But what is noticeable here, even if we place the lens in the sulcus and the patient will get vision, but we need to make sure that we suture these wounds more so because there is as you can see, quite a big wound burn. These wound burns are in phaco are very notorious, as has been discussed earlier also. Like they give a gaping and tends to take a very long time to heal. Well, this is another one, a black cataract and look at what Dr. Mohanto is doing. He is actually preparing this case, a nice tunnel, just as a backup strategy. Although phaco will be attempted, but since it is such a huge black cataract, as a backup strategy, a tunnel is made, a scleral tunnel is made, a deep groove is being done to prepare for chopping. And as you can see, this we need to go very deep, as Dr. Arup has said. And once this is done, chopping is being tried. Not a very clear-cut chopping could be achieved. Multiple attempts of chopping in this dense hard nucleus was done, but it was soon realized that it would be next to impossible. And once we keep doing this, we may end up with lot of collateral damage. So no egos hurt. It's being converted to an SICS. And as you can see, it's prolapsed, the huge nucleus is prolapsed into the anterior chamber. There is a MyLoop. MyLoop can be used. MyLoop can be used to cheese wire the lens inside the bag, or a homegrown snare, where snare does the same thing when the nucleus is prolapsed into the anterior chamber. And see how well it can cheese wire and cut into smaller pieces. And then with the irrigating vectis, each of the pieces can be taken out. And that gives us good comfort because there is very little collateral damage. Had we continued with the phaco, there could have been massive complications, long-term issues would have cropped up. So this is how we can place the lens and give a good, comfortable vision to the patient. Now, many times we have a moderate sized pupil and we feel that, okay, we can carry on with this pupil. Once we give the triple blue, I realized that the pupil is becoming smaller slowly. So in all these situations, first we attempt with little, mydriatics, and if it doesn't work, we need to keep handy hooks and rings. I prefer the rings because it causes less distortion of the pupil. And yes, unless we do this, we will actually not realize, we will not know what lies beneath this small white sheet of, cortical cataract. There could be a dense hard nucleus. So that is how, once the first step is correct, once we make the opening wide to give us a comfortable view, we can go ahead and do the rest of the things. Sorry, this video has stopped. I'll skip to the next one. This is another one, hypermature Morgagnian cataract. And as you can see, the cortex has liquefied and got absorbed. And this every step is important here because, this kind of capsules which are calcified are very difficult to tackle. Let us see what Arup does. It needs to be done very carefully because, as we know, once we run into one of those calcified spots, the rhexis can quickly run into the periphery, because the whole vector changes, the directions change. And that we need to keep in mind. And as you can see now, it's running into the periphery and it's almost not retrievable. So this is how we need to be extremely careful. A small snip can help us continue the rhexis and complete it so that we have big enough rhexis here. And now tackling this hard, dense nucleus. As you can understand, the bag is not so stable and to continue phacoemulsification within this bag, and it's going to be extremely difficult. It will keep moving, no support. So it's being brought into prolapse into the anterior chamber, and once again with a wire snare we can actually, it is being divided into multiple pieces. First two big pieces, one piece would be, it's easy to cut through, and then as you can see, one big piece, one small piece. And then what he does is he wants to take out that small piece by phacoemulsification, of course, and of course, after giving a lot of viscoelastic. Here, it is important to note that while you do phacoemulsification in these pieces, we need to remember that the other big piece may, if there is slight turbulence, the other big piece may actually cause damage to either the posterior capsule. As you can see now, it's becoming uncontrollable. So here it is being put again back to the anterior chamber and put into a side, and to give a support to the posterior capsule, multi-piece intraocular lens is implanted to act as a IOL scaffold. This scaffold would give support to the, it does not destabilize the posterior capsule, and also it stabilizes the anterior chamber, where we can keep doing the phacoemulsification with much ease. Otherwise, this would be unsettling, and this big piece could have, hit the posterior capsule as well. So now with the scaffold in place and further division of the big piece, it can be very easily emulsified. And then once the emulsification is over, we can go ahead and place the lens securely once in the sulcus, and then we need to capture the optics in the rexis to stabilize the bag and the lens. So to stabilize the lens, it is important here. This is the last case where, as you can see, another hypermature Morgagnian one, where the liquid cortex has already been absorbed. And what you can see here is, again, a lax, very lax or unstable bag. And again, to be noted how difficult it is to do a good rexis here. And once you start doing the rexis, you'll realize that these folds are appearing, which indicates that the zonule is also maybe not intact there. So there is a subluxation, but it's not obvious because of the, very empty bag. And this is where we need to keep injecting viscoelastics off and on very regularly, so that we can complete the rexis with a lot of effort. We need patience. A lot of patience is required here. And once this is completed, we need to check the integrity of the bag. Now here, before completion, you can see it's difficult here because the zonules are not there at this point of time. So we need to snip it out with the macro scissors, and this completes the rexis. But for any further management of the nucleus, what we need to do is we need to put a lot of viscoelastic and then stabilize the bag. For stabilization of the bag, we will need to put capsule tension ring. A CTR will be implanted here, and with the CTR, the bag needs to be stabilized, because the size of the rexis will not allow, it needs to be extended further. It needs to be made bigger, because it will not allow prolapse of the nucleus in the anterior chamber if we want to manage it. Now, a small snip is made and the rexis is being extended. Once you put the CTR, the bag actually becomes quite stable, and that is how it permits good rexis here. And then what we need to do is take out the nucleus out. So what he does, he gently inspects the bag properly and then takes the nucleus out in the anterior chamber. And once this is done, the bag is properly inspected after inflating with a lot of viscoelastics. And thereby, it's obvious now that the bag is not very stable and we have zonular dehiscence there. So what is again done is IOL scaffold. I'll just move forward a little bit with this step. Once the IOL is implanted, it acts as a scaffold here, and once it is stabilized, we go ahead, and now this nucleus has to be dealt. This time, this is something innovative. Lens cutter is being used to cut the nucleus, and it looks very simple and elegant. It's cut in a very nice way, and you can make multiple pieces as well if required. This is one big and one small, and the bigger piece is again cut into two halves. So this becomes really small pieces, and then phacoemulsification is carried out. Once the phacoemulsification is done, the lens is properly placed and stabilized, and vitrectomy had to be done, and later on a little bit of triamcinolone is given to look at if there are more vitreous stents. If it is not there, it's closed. Thank you.